Welcome to my vlog where we'll be discussing skills versus capacity in the weight room regarding the squat and overhead press. Throughout the video, I aim to analyse the movement during the exercises, discuss potential skill and capacity deficits, highlight these with further assessment, and then look at corrective strategies or alternative exercises in order to achieve the most effective movement strategy for the athlete. First athlete we're going to look at is someone performing a squat with a skill related issue. From this lateral perspective, we see the athlete initiate the descent phase, flexing at the hip and knee near simultaneously. The athlete then increases trunk flexion velocity, displacing the load anteriorly. As the athlete reaches the bottom, we see a lack of depth, increased trunk flexion, and an anteriorly translated bar. Still image with angular measures will demonstrate a large amount of trunk and hip flexion, less than 90-degree knee flexion, and the bar in front of the knees. This will cause a centre of mass to shift anteriorly, leading to increased lumbar load and the athlete to initiate the ascent phase, pushing up through the forefoot. Assessing the athlete from the front and back, we see they have a tendency to drop into knee valgus and overpronation at the ankles, demonstrating an uneven bar distribution as well. In order to differentiate if this is a skill or capacity limitation, we can quickly see the athlete has good passive hip flexion, both left and right, and good external and internal rotation, both left and right. Functionally, he's able to pole squat well, demonstrating good functional hip flexion capacity. We can also see from a kneeling dorsiflexion test of around 5 centimeters left and right, although limited, he is able to get his knees beyond his toes. Having demonstrated that the athlete has many of the physical capacities necessary to squat, we can go down the potential corrective strategies for this scenario, which may include initiating squat with the hips, pushing these out or increasing hip external rotation, and pulling the hips through at the bottom. Simple alternative exercise such as the goblet squat gives the athlete a counterbalance, encouraging a chest up position and allowing them to push the hips back, knees out, pull the hips through at the bottom and sit between the legs while generating tension through the back. Here we see front to back comparisons again, where there's less knee valgus, less overpronation, allowing the athlete to achieve greater depth and increased stability. From the side, we can see that this has allowed the athlete to drop in between the legs, and pulling the hips through at the bottom encourages a more upright trunk position, keeping the load more central and closer to the midfoot line. Now we'll look at our second athlete doing the back squat. We see that he initiates the downward phase with his hips, reaches maximum dorsiflexion early, increasing trunk flexion velocity to compensate. Here we see a large amount of hip and trunk flexion, shifting the load in front of the centre of mass, creating excessive forward lean and shifting the load anteriorly, resulting in the athlete to initiate the upward phase through the back extensors. From the anterior and posterior views, we see the athlete demonstrating good external rotation at the knees and doesn't overpronate. So looking at why this may be the case, functionally we can see he has good forward flexion, however is extremely limited into standing extension. Dorsiflexion is limited both left and right, barely being able to reach the knees over the toes. During a pole squat, we see the athlete avoiding dorsiflexion and favouring a hip and trunk flexion pattern. Naturally, we see little cause for concern, with a mild right foot overpronation, slightly elevated left shoulder, and protracted shoulders from the lateral views. On further investigation, we see the athlete has limited passive hip flexion both left and right, just beyond 90, along with limited internal rotation and external rotation is within normal limits, both left and right. The athlete demonstrates a complete lack of ability to extend the thoracic spine. We have shown that there are a number of capacity related deficits with this athlete, where there are a couple of simple strategies to try and determine how best to overcome the limitations and create the most effective movement strategy for this athlete. By putting in a simple heel raise, we put the athlete into plantar flexion, compensating for the lack of dorsiflexion. Although we still see a lack of depth, we can see this allows the athlete to keep a more upright posture and the load more central over the midfoot, allowing them to initiate the upward phase by pushing through the heels rather than extending the lower back. We see with a goblet squat, shifting the centre of mass anteriorly allows the athlete deeper and encourages a more upright trunk position, but the squat is still limited. By combining both interventions, this allows the athlete to execute the most effective movement strategy, the more upright trunk position, more hip flexion, getting to just beyond parallel, and executing a safe and efficient upward phase. Now we'll look at an athlete who expresses a skill-related issue in the overhead press. As she initiates the press, we see the bar travel forward, finishing above and in front of her centre of mass. As she approaches a peak of the upward phase, she extends at the thoracolumbar junction and raises her ribs to counter her change of centre of mass. From the front and back, we see limited co-activation in the abdomen and glutes, and her elbows flare out, with her right arm not reaching maximum extension at the top. Looking deeper into this athlete, from the lateral aspect, posturally we see there is little of note. From the back here we see she has good scapular positioning. From the side here we can see she has good active external rotation and shoulder flexion. She has good scapular control during both forward flexion in the upward and downward phase, and shoulder AB adduction in both the upward and downward phase. We can also see here that she has good capacity to extend through the thoracic spine. So we have demonstrated the athlete has all of the functional movement capacities necessary to perform the task. So our corrective strategy should focus on cueing the athlete to re-educate the movement pattern, including bracing from the abdomen and glutes and regressing the exercises, such as a single arm half kneeling shoulder press. While in this stable position, we are able to encourage co-activation of the glutes and abs with less need for thoracic extension. This can be advanced to split stance overhead press, where we encourage the same co-contraction while allowing us to teach a better bar flight route. To finish, we see the athlete now has good co-contraction of the abdomen and glutes and a more effective flight path of the bar. They end at the upwards phase with the load midline of the centre of mass. So moving on to our final athlete who has capacity-related issues during the overhead press. We see he initiates the upward phase with excessive thoracolumbar extension in order to keep the load as close to midline as possible, essentially pressing the bar up and forwards using anteriorly dominant structures, reaching peak height in lumbar extension with the load anterior to his centre of mass. During the downward phase, we see him adopt a similar strategy, extending through the thoracolumbar spine, putting excessive load to the lower back. Looking at the athlete outside the movement, posturally we see he is lumbalordotic, kyphotic, and is protracted through the shoulders, and his scapula are slightly upwardly rotated. We can also see he generates extension through his thoracolumbar region. Here we can see he is very limited into external rotation at the shoulders and lacks the capacity to fully elevate the arms through abduction with external rotation. Functionally here, we observe that the scapula, while starting slightly upwardly rotative, possibly due to the kyphosis, are controlled well through elevation via abduction and forward flexion during both the upward and downward phases. So we've clearly demonstrated that the athlete is limited by their capacity to extend through the thoracic spine and fully flex at the shoulder. Therefore, a corrective strategy will be to work on trying to improve these limitations over a long period of time using various modalities. However, in order to allow the athlete to execute the most effective movement for them currently, regressing the exercise to a simple half-kneeling single-arm landmine press would work well. This allows them to maintain a neutral lumbar spine and progress safely, encouraging more shoulder flexion by shifting the body closer to the press. Although we have classified the deficit seen as capacity or skill related, it's important to note that both may be present. As skills require coordination, balance, and motor control, capacity limitations exist through arthrokinematics and the ability to express and endure force production. While it's my view that physical capacities may determine our ability to perform a skillful movement, while a motor control deficit may be improved by coaching, as demonstrated here, a physical capacity may limit the athlete's ability to perform a specific movement safely. Therefore, as well as an intervention strategy, an adaptive exercise routine that allows the athlete to express the skill and movement pattern safely will be necessary.